The Mental Health Desert, Crisis Assessment in Rural Areas. Imagine you're a middle schooler, and you say to your friend, "I want to kill myself." When the counselors hear about it, they call your parents, and before you know it, you're on your way to the emergency room. You might not be in immediate danger, but there's no one at the school trained to figure that out. In rural school districts, this isn't a rare situation. It's reality. A really important topic when it comes to rural communities is the mental health desert, which are areas where mental health access just isn't there. Rural areas make up about 97% of the land in the US, but only about 20% of the population lives there. That means resources, especially like mental health care, are spread very thin. In fact, in many rural communities, there are fewer providers, longer travel distances, more financial barriers like poverty, and higher stigma around seeking help. For youth, it's especially important to discuss mental health. Suicide is currently the second leading cause of death among middle and high school-aged youth. Moreover, youth in rural areas are actually at higher risk. Suicide rates among rural adolescents are nearly twice as high as those in urban areas. At the same time, they are less likely to receive mental health care, more likely to experience poverty, and more likely to face barriers like transportation. Big picture, we have a population with higher need and less access, a mental health desert. How do schools and mental health intersect? Schools serve as primary access points for essential resources because it's where children spend most of their time. They often provide or facilitate screening and assessment for mental health and learning disorders, as well as referrals for higher needs. But in rural areas, they're often the least equipped to respond. School staff are expected to handle crises of all kinds, but without the staff, funding, or training that would make that possible. Beyond that, risk can be complicated. There's an important difference between long-term risk factors like depression and immediate warning signs of suicide. Warning signs for suicide are things like talking about wanting to die, increased substance use, extreme agitation, sudden withdrawal, or mood changes. Without any training on the difference between them, it's easy for already scarce resources to be lost. So what can be done? Research says that universal prevention, targeted support, and crisis response is the best way to go. One of the most important things schools can do is feature gatekeeper training and quick psychoeducational models. The community, made of teachers, staff, and students, needs to learn more about suicide and suicide prevention. Programs like QPR, which is Question, Persuade, Refer, Youth Mental Health First Aid, and the model is Path Warm, can be extremely effective in teaching the community what to do when someone is hurting, how to recognize what's happening, and how to respond. One of the most well-known suicide prevention programs is QPR. Let's quickly go through it. Maybe a student says, "I just don't see the point anymore." Q stands for question. This is where you check in with them and clearly ask, "Are you thinking about hurting yourself?" You ask directly, no beating around the bush or being vague. Research shows that it doesn't increase any risk to ask. P stands for persuade. Thank them or tell them you're glad they told you. Tell them they don't have to deal with this alone. This step is important in showing them that someone cares. R stands for refer. Your goal is to get them to someone who can help. That's most often a mental health provider or the hospital, but in schools that's often a teacher or counselor. The whole point of QPR is to make sure they're safe and supported, and if they need help, they're not alone in finding it. School-wide suicide prevention programs are important, and psychoeducation about suicide can help students and staff feel more comfortable about acting. Another thing schools can do is build community connections. One of the strongest protective factors against suicide is having one trusted adult to talk to when things become overwhelming. Not every student is without a trusted adult, but many at-risk children are. One way that schools can help students find a trusted adult is with mentoring programs. These programs pair students with teachers, coaches, and upstanding community members, especially first responders like firefighters and police officers, as well as retired professionals. This way, students can build real and protective relationships with positive influences. Consistent, supportive check-ins can mean all the difference when it comes down to whether a child will disclose suicidal ideation or intent. In rural communities, this intervention is powerful because relationships are already a strength. Rural communities tend to rely on one another more and band together when there are needs. Mentoring programs mirror that inherent strength and give community members a sense of purpose and belonging. Now, we discussed a school-wide prevention effort. Then we discussed a mentoring program for at-risk students. What about the students that need direct help? That's the biggest gap in many rural areas. Schools need someone trained to assess suicide risk, determine the level of danger, and decide what to do next. That's where a school social worker can come in. School social workers are trained to handle both district-wide needs and direct therapeutic services in the short term, especially in crisis assessment. Rather than sending every student to the emergency room, school social workers assess risk, develop a safety plan, notify the parent, and make the final call for whether the student is in immediate danger or not. This role is vital in reducing expensive, unnecessary emergency room visits while still protecting students. But of course, reality comes knocking. Of all those barriers to mental health access in rural schools, the one that stands directly in the way of hiring a school social worker to head all of these interventions is funding. There are a few ways that school districts can work around a thin budget, but one of those is using a blended funding model, which really just means sticking their hand into multiple money jars. House Bill 268 was passed last year, and it provides salary reimbursement for student advocate positions, a position that is essentially a school social worker. But as with most funding, it has limitations. The bill only reimburses up to $10,000 when serving smaller student bodies. That alone is not enough for a school social worker. Some options districts can look into include Medicaid reimbursement for eligible services like short-term therapy, other grant opportunities through federal avenues or nonprofit agencies, or community partnerships relying on donations. Those can offset the cost so districts can have an easier time funding a school social work position. At the end of the day, this isn't just about resources. It's also about access and what services students should have available to them regardless of where they live. Rural schools have different needs compared to urban schools, so they need interventions that capitalize on rural strengths while also utilizing standard professionals to fill specific roles and reduce gaps. With the right structure, like prevention, connection, and a trained responder, mental health deserts can quickly become systems of support.